Dr. G.S. Wonder, Dr. Shekha Gupta, and Dr. Vinod Singh as our judges. Kindly be seated. Is rapid establishment of ECMO program during COVID-19 pandemic.
Good morning. I'm coming from Saudi Arabia, beautiful city called Najran, in the south of Saudi Arabia. I am presenting today on behalf of my team. First topic about rapid establishment of ECMO program during the COVID-19 pandemic. So, extracorporeal membrane oxygenation is a modality used in management of patients with refractory cardiogenic or acute respiratory failure. During 2020, the world suffered from COVID-19 pandemic, so number of cases and centers offering adult extracorporeal membrane oxygenation has increased. Right. Honestly, we were not planning to establish a program in response to COVID, but we started 1 month before. But the COVID pandemic made us to in hurry to establish this program. So our objective to analyze our experience in King Khalid Hospital in the Grand Saudi Arabia. So here is our center. This is our center. We rapidly developed and implemented an organized ECMO program in King Khalid Hospital. So this program started by preparing policies and strategies, followed by training of multidisciplinary team of doctors, nurses, RT specialists, and perfusionists. Then starting the service with continuous training and improvement, including workshop, hands-on training, and lectures. This is our organizational chart, ECMO program director, with ECMO nursing co-director and chief of RT. We are using nursing RT model. Here we have ECMO surgeons, ECMO coordinator, ECMO perfusionist, ECMO physician, and here is ECMO nurse specialist and ECMO nurses, bedside nurses, and here RT. And RT, they are RT for ventilator and these things, and they are ECMO specialist RT. This is our policies. We have many policies dedicated for ECMO, and we have job description of each position I mentioned before. We have separate privilege for ECMO doctors, and we have separate competences for ECMO nurses. Here is some lectures of our staff in the start and hands-on. This is the first batch of nurses graduated from our training. I think 90% for this batch was Indian, and until now my 80% of my team is Indian. We have a great support from MOH ECMO team for training and supervision. And finally, we became an ELSO center, being the fourth center in Saudi Arabia and designated this year as Silver Liver Center by ELSO. This is some training by MOH team. We have some workshop done by Ministry of Health team. So our result, until December 2022, we have 85 patients treated with venous and veno-arterial patients. Survival to decannulation 75% and survival to hospital discharge of 55%. All patients are initiated and managed by our ECMO team. This is the first cannulated patient, and this is some of our retrieval cases. We have 20 retrieval cases, both air and ground. Complication includes hemothorax in 6 patients, head in 3 patients, oxygenator failure in 3 cases, oozing from cannulation side in 10 cases, oral cavity bleeding from tracheostomy, and renal impairment failure represented in 39% of cases. So this is some videos of our patients. All patients agreed and consented to have their faces and for media and training purpose. This is one patient, a weight patient. This is another patient eating while on VV ECMO. This is another patient, also VV ECMO, walking. And this is one of our patients and the hospital guard while on face mask and VV ECMO, flow 5, 100 on ECMO, sweep 3. So the results suggest that rapidly developed ECMO program can provide safe service and provide outcomes similar to those in the existing literature. Key components are an institutional commitment, a physician champion, dedicated leadership, multidisciplinarity, and organized training. These are some thankful pictures from our patients. This girl or lady was Indian nurse. She was pregnant in 4 babies, and she was on ECMO, and now she's okay. This is one patient who has chronic renal failure and ischemic heart disease, has COVID and developed ERDS. Now he's okay. And this is a prize from the Ministry of Health, being the first center and the patient experience during 2020. Thank you. So my second talk about ECMO as a life-saving modality in near-fetal asthma. Our talk about ECMO as a life-saving modality in near-fatal asthma and ground experience. The use of extracorporeal membrane oxygenation ECMO in cases of near-fetal asthma has increased, but the benefits of this therapy have yet to be fully investigated. However, its use in severe asthma is limited to case reports or cases. So, it is a retrospective study of a near-fatal asthma patient received VV ECMO in our emergency department at King Khalid Hospital, Najran, between 1st January 2022 and 1st December 2022. In this study, we analyzed 5 cases of patients with bronchial asthma were presented to emergency department in severe fatal asthma. These 3 patients presented with severe hypercapnia and severe respiratory acidosis, and intubation was done in ER. 2 of them developed cardiac arrest during their management of asthma. Time of arrest ranges between 2 and 4 minutes. While other 2 patients brought arrested to the emergency department and CPR was done for them, ROSC was obtained in 5 and 18 minutes respectively. Vigorous asthma management in the form of muscle relaxant, sedation, PRBC ventilation, and aggressive therapy for bronchial asthma was started for all 5 patients, but their condition was worsening and no improvement obtained. ECMO consultation was done in emergency department, and VV ECMO was started for these patients. PIMJAC configuration was used with gradual correction of hypercapnia from elevation of EBG obtained later with continuity of conventional asthma treatment. Mean time of ECMO run was 128.3 hours. 4 patients extubated before ECMO decannulation, while 1 patient decannulated while on ventilator. Ventilator settings were significantly improved after ECMO initiation in all patients. Weaning of ECMO was successful in all 5 patients, and 4 patients were discharged home. 1 patient who was prolonged cardiac arrest before initiation developed irreversible brain damage and died later in ICU. So, ECMO as a life-saving in patients with severe fatal bronchial asthma whom conventional therapy failed, and it is associated with good outcome. However, bigger study should be performed. Actually, in my journey of education of my staff, ER doctors, about the indication of ECMO, one of ER consultants said to me, when I said to him about bronchial asthma, he said to me, patients with bronchial asthma need a good doctor, don't need ECMO machine. But this doctor, who is the first one who asked me for 1 patient who failed with him to do conventional therapy for fatal asthma, and this patient was successful. So now I think, but I can't conclude that ECMO is life-saving modality. We need a bigger study to see. I'm a cardiac surgeon. I can't admit that I know all the management or conventional management of asthma. But when the doctors fail to treat asthma, ECMO can be a solution. Thank you. Any question? Thank you.
Our next presenter is Dr. Shizu Kumar. His topic is neurodevelopment outcome in children undergoing ECMO.
Very good. Good morning, everyone. So, I'm Dr. Shiju Kumar, consultant pediatric emergency and critical care from KIMS Trivandrum. So, the aim of my study was to study the neurological complication and neurological outcome in the children who got the ECMO support. The single center experience. So, we did a retrospective study. We started from 2015 and we included the last year study also. So, neurological outcome, we documented GCS at discharge with the pediatric overall performance category and development assessment at follow 3 months and 6 months follow. We included 3 months follow. So, total number of children on ECMO we did was 14 and mean age was 5.7 years, lowest age was 10 months, mean ECMO duration was 10 days and maximum ECMO day was 18 days. Some more. So, a combination is BB mode, and most of the time it is indication of acute respiratory distress syndrome, 64%. And one patient we have to do change to BB to BAB to develop septic shock, and others are VA and two central cannulation. So during cannulation, we have a challenging case with a difficult duplicated IVC. In fact, we go on pump for emergency situation in 2 hours. It took almost 4 hours. Luckily, with the help of the intervention radiologists, we were able to do VV ECMO during that time without opening the chest. So this is a picture of DEE of duplicated IVC. So most of the indications are ARDS, and the outcome in ARDS are 55% survival to discharge. So others are cardiac indications. So cardiac the outcome was better for us. In fact, we did ECMO for 2 MISC patients. So most of the survived after decannulation. One died later due to critical illness, polyneuropathy. So when we looked at the data, we found that the children with septic shock associated with ARDS had a bad outcome. Almost 3 patients on ECMO died. So we also asked the question, should we try a central ECMO for distributive shock? Because the MISC, the physiology wise, both had a distributive shock. The central ECMO, there was 100%. So neurological complication, one child on VA ECMO had a severe ARDS septic shock, died of intracranial bleed on day 4. The other boy, as I said, was decannulated, but he developed a critical illness polyneuropathy. We sent him on home CPAP, but later, unfortunately, came with a tracheal bleed and died. So we tried to evaluate the possible risk factor for the intracranial bleed with the help of the literature. So we evaluated the data of platelet thrombocytopenia, which is less than 50 severe, ACT more than 190, hypertension, CRRT, and the pre-ECMO PCO2 of 70 with a rapid drop. So when we evaluate the child with intracranial bleed, almost had all the risk factor. In the literature mentioned low pulse pressure as another risk factor like intracranial bleed. They also registered say almost 10% can have IC bleed. ECPR had the highest. So our neurological outcome at discharge, 4 survived, had almost GCS of normal in almost all patients. One child had a learning disability. So the literature says as many as 10 to 50% can have a cognitive problem. This is a recent paper. Again, it says 15.6% can have a neurological complication, which includes seizure, intracranial bleed, or brain death. So at the end, when you evaluated, so almost 7% had the neurological complication, and at discharge, almost 80% were normal. So almost everybody is doing the normal school performance, no issues. So all are retrospective data, and probably we need a multi-center prospective data to find out the multi-factor risk factor which can be intervened. So acknowledgement. Thank you.
So one quick question would be, you used in this a very well done study, and I applaud you for following up on these children and seeing how they do long term. You chose to use PCPC or POPC for this. Did you look at any other scoring systems? What made you choose that one?
No, retrospectively that is easier. That is the only reason.
Okay, fine. It's there are multiple options out there. It's always interesting to see why people choose. Excellent presentation. Thank you.
Thank you.
Thank you, sir. Next presentation is by Dr. Sulakshana. Her topic is extracorporeal membrane oxygenation in COVID-19 Indian scenario.
So this was my thesis topic for the ECMO fellowship, and it was on extracorporeal membrane oxygenation in COVID-19 and the Indian scenario. Before I start, I would like to thank my co-authors or my mentor, Dr. Arpan Chakraborty and Dr. Dipanjan Chatterjee, who helped me out. I did my fellowship under them. So we all have witnessed the recent pandemic when there was a surge in the cases of COVID-19 starting from Wuhan, China, and there was quarantining, screening, everything going on. And at that time, people were having multi-system inflammation, especially on the respiratory system. So the data says that about 20% of infected population required hospitalization, out of which around 26% required intensive care unit admission. Now, various data suggest so much variation in it, ranging from 30 to 88%. Patients afflicted with COVID-19 have been shown to require invasive mechanical ventilation in various settings due to development of severe ARDS. So despite best supportive care with lung protective ventilation, pulmonary vasculitis, neuromuscular blockade, prone ventilation, everything mortality still remained high. So this was how the COVID-19 was rapidly involving the lungs in so many cases, leading to mortality. So there was a dilemma initially when it started that it was a pandemic situation, putting a strain on the already existing healthcare resources, and there was a clear-cut strain. We were not really prepared for that, so there was strict lockdown during the initial wave, and it was an extremely contagious disease. Healthcare workers who were for the treating the patient were also very much exposed, so they were also having family and everything for that, and there was really a resource limitation. And early studies from China was very unfavorable, showing 83% mortality. But this 83% mortality data came out of only 6 cases. In those 6 cases, the case series, 5 patients died, only 1 patient survived. So initial data cannot be projected to the second wave actually. So we are doctors and we cannot sit idle. We can do whatever we can. So so there was clear the dilemma. But in interim guidelines of ELSO, they didn't deny, they said that they were against initiation of ECMO before maximizing traditional therapies and particularly prone positioning. So they said that ECMO should be, because there were earlier experiences from the MERS or the swine flu, everything. But because it was a pandemic situation, the interim guidelines said that first you should use all the available therapies, then you can think of it. They were not against that, and they were, and the indication contraindications were almost same. So here you can see that mechanical ventilation more than 10 days was a contraindication, absolute contraindication. So again, there was a dilemma, because in India we know that there are so many centers where people were not intubated also. They were on HFNC, they were getting so many patients self-inflicted lung injury, and when they were crashing, they were just referring to some higher center, or all hospitals were overburdened. So in 2021 ELSO guidelines, they again gave an algorithm. And according to that algorithm, while it may be tempting to stretch the use of conventional therapy to avoid placing patient on ECMO due to resource constraint, there is no evidence to support delaying ECMO initiation when it is indicated. So this is when that so many centers came out with ECMO as a treatment option. So patients who are deteriorating in non-ECMO centers should be referred early for ECMO consideration to allow for safe transport or time to organize mobile ECMO rescue in appropriate patients. So increased use of ECMO had varied outcomes. So this study was intended to analyze the socio-demographic characteristic, type of ECMO, duration and complications. So this was my objective. Patient important outcomes I have to study. It was a single center retrospective study. Study period 1st June to 2020, 31st May 2021, and data collection included demographics and the ECMO related study. This is my result. So age, total population was 79, 71 males, and in all data you will see the male patient was in contrast to a very high number compared to female sex. So 10% was the female sex, body mass index was 37. Usually they were on the heavier side. So hospital admission to intubation was around 5.1 to plus minus 3.8 days. Chronic pre-ECMO is 65%. There is some bias in it because 38% of patients were rescued from other centers. So we didn't have the retrospective data. We cannot include that. That's why, as the guidelines say, that 100% should be used for prone therapy. But there was missing data. That's why there is some bias in this data. Now, intubation to ECMO initiation usually 54 to plus minus 36 hours. Proning on ECMO 25%, and that was a good favorable outcome for proning. Awake ECMO in 2 patients for 2.5%. Prolonged, I'm sorry, it is more than 14 days, not 4 days. It was ECMO run was very high, longer compared to other viral or other indications. Now, tracheostomy was done in 70%. Sepsis was the main cause of mortality. It was in about 65%. Sepsis was taken when the culture was positive. No other biomarkers or anything. So renal replacement therapy required in 39% cases. Bleeding complication in 1.25%. Only one case of ICH we had. And sudden occipital clot in 2.2 cases where the patient suddenly died. And cytosol were used in mean length was higher, 17 point plus minus 5.2 days. Highest duration was 66 days. Patient didn't survive. Highest. So initial veno-venous was 87%. Initial veno-arterial was 13%, where there was septic shock converted to VAV. Repeat ECMO in 5 cases, none survived. And ongoing ECMO on the day of data collection was in 5 cases. So decalculated but on ventilator 1.25. Now referred cases were 30 cases. 2 cases were air retrieval, 28 were ground retrieval. So the limitation of this is the patient selection criteria not very stringent. Duration of intubation to ECMO initiation could not be protocolized. We didn't study the mode of ventilation pre or post ECMO initiation, and referred cases were high in number. An organ failure assessment score or rest safe score could not be calculated due to missing data. So my conclusion is that mortality rate of COVID-19 patient on ECMO were comparable. Runtime was quite longer, and it should be considered as a treatment option in COVID-19 cases. However, if the capacity diminishes, the ECMO consideration should be based on more stringent criteria. Thank you.
Which institution was
Medica Super Specialty, Kolkata.
that? In Calcutta. Thank you.
Our next presenter is Mr. Bilal Ahmed. His topic is incidence and outcomes of neurological complication in H1N1 respiratory failure patients on ECMO, a retrospective study.
Good morning, everyone. At the outset, I would like to thank the organizers for allowing me to present a paper here. This is also my thesis topic for my fellowship. And also, I would like to thank my alma mater, that is Riddhi Vinayak Hospital, which has been awarded as a platinum level ELSO center for ECMO program. And this is where, and I would like to thank my mentor, Dr. Venkat sir, and Dr. Myself, and also my team at Riddhi Vinayak. So just introduction, like why it was called as swine flu, because it was initially the virus was detected in the pigs, and then actually there was a pandemic in 2009, which led to the actually I was working in Narayan Rudra in Bangalore at that time, and we had an Australian team which came from Australia for the ARDS, and we had 47 cases of H1N1 ARDS which were treated, and that was the first thing which we uncovered with the ARDS. So as we see from the after the Caesar trial, And even as the previous speaker told, in the COVID-19 era, the use of ECMO in adults have increased. So, as such, actually, even though the ECMO gives a temporary rest to the lungs, so that the lungs can heal and recover from the ARDS, still there are some complications which can occur, which are inadvertent, which we need to assess. So, in the health registry, if you see that until now, 88,000 respiratory ECMO cases were recorded, and the survival to discharge was around 58 to 73%. There are many factors which affect the outcome of ECMO, and amongst them is the pre-ECMO pH levels as well as the pre-ECMO partial pressure of carbon dioxide levels. So we see that there are significant proportion of patients have hypercapnia before ECMO initiation. That can be due to lots of our permissive hypercapnia ventilation strategies, which may be one of the cause. Even the EOLA trial, which also showed that there were 47% of the patients had PSCO2 more than 55. And so hypercapnia and respiratory acidosis are likely a marker of underlying severity of the disease. Our center planned to analyze our data and find out the correct correlation of pre-ECMO, PSCO2 and pH levels with outcome and significant neurological complications. So there might be like a variety of factors which might be hypoxia, hyperoxia, electrolyte imbalances as well as sedation strategies. And ECMO related might be a thrombosis, hemorrhage and infection. So these complications can range from mild delirium confusion to severe neurological injury, intracranial hemorrhage, including thrombotic stroke, seizures, and even brain death. So we designed a retrospective observation study for all respiratory ECMO, including neonatal pediatric adult, and which were managed by the Vinayak multi-specialty hospital team. And the period which we took into consideration was from 2010 January to 2021 December. That was 11 years data. We extracted the data on all patients who received ECMO primarily for respiratory failure from our institutional ECMO database. So all modalities of VV, VA as well as hybrid ECMOs were included in that. And we created two groups of survivors versus non-survivor, which were compared by a bivariate analysis with regard to demographics, clinical and ECMO post-category. So differences between the two groups were analyzed and p-value obtained by chi-square two-variant calculators. P-value less than 0.05% was considered significant, and the data was analyzed by primary outcome as a goal of survival to discharge to home, and the secondary outcome was the number of ECMO days and the incidence of neurological complications. So data analysis was done with pre-ECMO PSCO2 levels of more than 45 and less than 45 with primary and secondary outcome goals. Similarly, the data was also analyzed with the pre-ECMO pH levels less than 7.2 and more than 7.2. So total patients which received respiratory ECMO in our institute during the specific period was 256, out of which we classified the data into three categories: COVID-19, H1N1, and others other than COVID-19 and non-H1N1. As a primary goal was survival to discharge to home, we had excluded 5 patients who were shifted to transplant centers. So total of 251 cases were analyzed, out of which 20 patients were of COVID-19 and 23% were of COVID-19, 36 from H1N1 and 41% from non-COVID, non-H1N1. So overall survival in respiratory ECMO was 38% with the maximum in non-COVID H1N1, and it was least in COVID-19. If you see that in H1N1, actually the survival rate was around 40% in our study. So survival to discharge chances were better in the group with less PSCO2 than which was lesser than 45. So however, it was less, like the p-value was not significant in the statistical analysis. So these were the things which we compare PSCO2 level of which was less than 45 and this is for more than 45. We see the survival rate in this was 5, and it was survival percentage was 33.33%. And in PSCO2 also again it was 37.18%. So coming to the pH levels, when we compared the pH levels at the initiation of ECMO less than 7.2 and more than 7.2, Again, it was noted that the pH was less than 7.2 had a higher mortality rate. So instead of and also we saw that the incidence of neurological complications and was higher in patients whose PSCO2 levels were more than 45 at the initiation of the ECMO. And also the pH was less than 7.2 had a higher neurological complications. So just a final recap, total cases were 256, out of which 65 were cardiac and 256 were respiratory. So the significant neurological complications which was seen in the respiratory cases was 10.90%. So we saw that just to summarize that prevention is better than cure, and we have seen that we can include the modalities to neuroprotective strategies to prevent the neurological complications rather than treat them. So that can include the clinical assessment, EEGs, TCDs, and cranial oximetry as well as radiological assessments, and to avoid hyperoxia as far as possible, wherever possible, awake ECMO, and to avoid hyperoxia and maintain normocapnia, and also optimizing hemodynamic support and electrolyte imbalances. So the conclusion, provides high important insights into the incidence and impact of neurological complications in H1N1 respiratory failure. Healthcare providers should be aware of these complications and implement strategies to minimize the occurrence. Further studies are needed to identify effective preventive and treatment strategies for ECMO-related neurological complications in H1N1 patients. Authors recommend early initiation of ECMO for mortality and morbidity. So,
Dr. Bilal, you talked about predictive hypercapnia, and at the same time you talked about PCO2 affecting your overall mortality rate.
yes,
So how much was the average PCO2 before you took the patient to ECMO?
Uh,
Those patients above 45 means unless you waited till 60, you waited till 50.
around the average was 55.
5
Yes, ma'am.
Thank you.
Thank you.
Next presentation is by Dr. Ambuj Yadav on topic problems faced during VV ECMO of a dengue patient with severe ARDS, a case report.
Very good morning to all of you, and thank you, respected chairpersons, for giving me this opportunity. So my talk will be on the problem faced during VV ECMO for dengue patient presented with severe ARDS. While we are living in a country like India, this is not very rare. Very frequently we get this type of patients suffering from tropical illness. So we thought of putting up this patient on ECMO because this patient was on with severe ARDS. So this patient was a 21 years old male with no previous history of chronic illness or addiction. He presented to us with high-grade fever with chills and rigors for 10 days, breathlessness for 2 days, and altered sensorium for 1 day. So on presentation, he was hypoxemic with a SpO2 of 76%. He was an altered sensorium, respiratory tachycardia, and the previous report was suggested of angus positive. So since the patient was in altered sensorium and with respiratory distress, we thought of intubating the patient and was shifted to medicine ICU, and the patient was ventilated with non-protective strategy. Post incubation, the saturation improved with SpO2 95% accelerated, which was suggestive of bilateral infiltrates. Initial investigation was suggestive there were patient was having thrombocytopenia, leukopenia, and transaminitis was there. Ferritin was pretty high, it was 40,000 nanogram per ml. Triglyceride was also here, also raised. There was splenomegaly and hepatomegaly too. Still, on the day 10 of the fever, the patient was having fever. Now, since usually in dengue patient, the fever does not stay till day 10. Now, since there was thrombocytopenia, ferritin was high, we thought of that this patient might be suffering from hemophagocytosis, and we gave the patient steroid and immunoglobulins. Now, even after that, it was day 5 of the patient on mechanical ventilation. You can see that the patient was being ventilated with very high ventilated pressure, with a peak of 16, and the patient sat for hardly 80%. So, we thought of putting the patient on ECMO after prone session. So was my patient candidate for the ECMO? Probably yes, because he was suffering from acute reversible respiratory failure with a PF of less than 100% despite polling session and my score of 3.75. But having said that, my patient was having, we were a little bit hesitant because my patient was thrombocytopenia with a platelet of 1.2%, which improved because of steroids and immunoglobulins we gave. There was transaminitis, liver function was deranged, but INR was preserved, it was 1.2. My patient was having normal renal function, echo was normal, and it was only day 5 of mechanical ventilation, and also the attendant gave consent to the ECMO. So we calibrated the patient, femoral jugular root was taken, and the patient initiated on BB ECMO. Anticoagulation used was unfractured heparin. After putting the patient on ECMO, the targets were set for the ECMO, and the patient ventilatory settings were the rest ventilatory settings. So we see the lactate, which was initially raised, they came out, they became normal after initiation of ECMO. The blood pressure, there was episodes of hypertension which were controlled by injection labetalol. So if you see the PF ratio, which were hardly less than 100, initially after initiation of ECMO, gradually the PF ratio improved, and the patient was decalibrated on the day 24. If you see the X-rays, you can see the second X-rays of post decalibration, and my patient was improved very well. But he was still on mechanical ventilation. So what challenges I face in treating this patient? Number one, coming on the central nervous system, if you see at presentation, my patient was having G, was in outer sensory diseases of E2, V3, M5. He had the bilateral constricted pupil. However, there was no focal neurological deficit. Now, on the day 5 of the mechanical ventilation, when we started initiated ECMO, still the GCS was M5. Whenever we stopped, we gave the sedation bed, the patient was agitated and was having GCS was M5. GCS was M5. Now it was day 7 of the ECMO. When in the evening we saw that the patient was having a GCS of even VT M1, the pupils were bilateral dilated and they were not responsive to light. Heparin infusion was stopped, thinking that this could be a case of ICH, and ECMO flow was increased so as to prevent the thrombosis in the clot. The other differential diagnosis was also thought. So we got an EEG done, which was suggestive of deep comatose stroke with a prominent delta wave activity. Now we see the imaging was done of the patient, that was suggestive of T2 and FAIR images clearly shows that there were hyperintensities in bilateral basal ganglia and was suggestive of ischemia. We did an MR angiogram also that showed that was suggestive that non-visualization of IC and its branches, but external carotid was pretty well visible. It also suggestive there was an ischemia going on. Now, if you see the Schwann images of the image, you can see there was blooming in the frontal, in the temporoparietal region, and in the lateral ventricle too. That was suggested that there was hemorrhage. So, what problem we faced was, despite having an patient, or this was the patient of any patient where we have the thrombocytopenia platelet dysfunction. So, was my patient having this problem, or was my patient on ECMO and with heparin? Was the complication was that we don't know. Now, second problem what we faced was with the gut failure. Now, the patient before the patient we put the patient at ECMO, the patient was feeding well on nasogastric tube, but after the patient putting on ECMO, there was a gut failure, total gut failure. We tried enteral feed, but the patient was not accepting enteral feed. We ruled out the other causes of the gastroparesis also, but nothing could be found. We tried progynetics also, but despite that, the patient was not responding. We put the patient on partial enteral lipid-free parenteral nutrition. Third, what we faced, we can see that on the day 8 of the ECMO, there was a rise in bilirubin with the rise in direct bilirubin more than indirect bilirubin. However, the SGOT and SGPT was not that raised. ALP was also not there, having this type of bilirubin, and we can see that the synthetic function of the liver was comparatively preserved with albumin of 2.9 and bilirubin of INR was also preserved. Ultrasound of abdomen, there was no objective evidence of any obstruction in the liver. There was no intrahepatic biliary radical dilation, and drainage curve was also frequent. There was no obstruction in that also. We ruled out the other processes like hemolysis. We don't have the facility of hemoglobin, but we did the other things like GBP, LDH, was binary range, but on GBP there was no evidence. Retic count was normal. There was no evidence of training. Other problems have also sorted out. Now, on the day 14, we thought of going for tracheostomy. After tracheostomy, the patient bled, and there was increase in peak pressure. So we did bronchoscopy, and bronchoscopic clot removal was done, and the lung compliance got improved post bronchoscopy. Cardiovascular function was normal throughout time. So on the day 28, day 24, we decalibrated the patient. On day 24, the patient again developed septic shock. The patient worsened, and apnea test was positive. The attendant was prognosticated, and end of life care was given to the patient. So to conclude, is the imaging before ECMO? We should go for imaging in the altered patient, especially in a dengue patient, because there can be many reasons of altered sensory in such a patient. was my dose of anticoagulation was adequate, because we saw the thrombotic and bleeding complication in the same dengue patient. Or the third was that the liver, which was already compromised in a dengue patient, may further deteriorate in a while putting the patient on ECMO. And lastly, the tracheostomy can lead to bleeding, which can lead to the lung compliance. And also, lastly, the paralytic illness, which was persistent throughout the ECMO run, was unexplainable. And this the question remains. And this was my team. I'm working in KGMC, and this is my team. Thanks. I want to acknowledge that. Thank you.
In the interest of time, we're going to move to the next one. Thank you very much. Thanks for that excellent presentation.
Walid Mohammed Hassan. He is going to present two presentations. First is on VV ECMO cannula shattering, and the second is on the use of VV ECMO in infant with human metapneumovirus pneumonia and ARDS.
Thank you so much. I am Dr. Walid Hassan, pediatric consultant from Kuwait. I would like to express my pleasure and thank you for the organizing and scientific committee for giving us this opportunity to present our cases. I would like to thank you by NN. I hope I will sound it very good. Okay, Bahud Dahal. Thank you very much. My first case is about the use of high frequency oscillation and VV ECMO with infants with ARDS to overcome femoral cannula shattering. This is my group of ECMO team. VV ECMO in pediatrics is a life-saving procedure that is being more recently used, especially in cases of respiratory failure with persistent hypoxemia and failure of conventional and high-frequency ventilation. Complications such as bleeding, clot formation, infection, and mechanical obstruction of the ECMO circuit may happen. Our objective in this describing this case report is to describe the benefit of high frequency ventilation used with VV ECMO in the case of shattering and low ECMO flow. Our patient, he is a 5-month-old girl, weight 5 kg, developed severe ARDS due to human metapneumovirus. And actually, since admission of this patient to our unit, he have a rapid course with severe respiratory distress, so he is intubated within 12 hours from admission to our PICU. Then, in the second day, we have to use high frequency to maintain his oxygen saturation, and used also the nitric oxide. In the first couple of 5 days, we have to struggle with his saturation. And on the 5th day, he developed persistent hypoxemia. And actually, we were in the weekend, and in weekend it is very difficult to hold even the subspecialty to do an echo for you. But fortunately, we decided to start this patient on ECMO, and actually this is the first case for us in Kuwait, and this age and this weight. We are using to start ECMO with the adult team under their umbrella. So we called the team and we prepared everything, and we have to collect the cannula and membrane lung from the chest hospital, which is not so far from our hospital. So we decided to start him on VV ECMO. We used to use right femoral cannula for drainage, 11 French Avalon, and right internal jugular vein for return, 9 French. And it was inserted, the femoral cannula was inserted by the adult ICU, and the right internal jugular was inserted by us. The patient, in the first few days, actually, the first 4 days of starting the ECMO, we were happy with the saturation, with the blood gases, with everything. But every now and then we have shattering, and actually the adult ICU they don't have an experience with the pediatric cases. So every day we think, and we shall we put another drainage? But as you know, the femoral line is very small, and actually we tried to use the right internal jugular to put another cannula, but unfortunately the dilator didn't pass. So we decided to keep the same as long as our parameter regarding the blood gases and the lactate and saturation is acceptable. Also, we have a problem with the lung. The lung of this patient, if you can see the X-ray here, there is bilateral infiltration, and we did bronchoscope as a lavage twice. But again, the patient progression it is not so good. So we decided after using the resting ventilator setting for the lung, we decided to put him on high frequency on the fifth day. And after we putting him on high frequency, we observed that the shuttering disappeared completely. We don't have problem with shuttering at all after that. Before you have to using it to give volume expander to position the leg, to abduct the leg, to move the leg. But after starting high frequency, we didn't have an experience with the shuttering again, and we try to think this is maybe due to the wiggling movement of the high frequency oscillation. So it prevents the cannula from touching the wall of the inferior vena cava. Also, our problem also this the cannula, the femoral cannula, it is short, so short, it's not long, and actually this was the size we have at that time. We continued on that using the high frequency to prevent our shuttering. So in conclusion, the use of high frequency oscillation with VV ECMO may help to solve the problem of shuttering and improvement in the drainage of flow in VV. Thank you.
You have another presentation?
Yeah.
You can go ahead.
Yeah. VV ECMO in an infant with human metapneumovirus pneumonia and ARDS. As a background, ECMO is a life-saving modality to support respiratory and cardiac failure patients. Recently noticed the emergence of aggressive human metapneumoviruses in infants. The use of ECMO was life-saving and successful by bilateral internal jugular vein cannulation. We reported a case of VV ECMO use in infant below 1 year of age. Our purpose here to describe the successful use of both internal jugular veins for cannulation. Our patient, he is ex-preterm, infant 27 weeks gestation, and the corrected age was 6 months. His weight was 8.3 with bronchopulmonary dysplasia, admitted to our PICU with acute bronchitis secondary to human metapneumovirus. He developed severe ARDS and resistant hypoxemia despite maximum ventilator support with high frequency and nitric oxide. He was commenced on ECMO, VV ECMO with cannulation of right internal jugular vein with size 13 French Avalon for drainage and the left internal jugular vein with 9 French for return. And actually, we learned from the previous case that the femoral vein will not help us much on the drainage. So we decided with the adult team to use the left jugular vein as this is the one we use this one, the right internal jugular for drainage and the left internal jugular as a return, and we call it as Faramani exercise because we have another case I will show you now. And we our concept about this to use as a double lumen cannula. Looks like a double. You will drain from here and you return to right atrium. So there is our venous ECMO used in infants was life-saving, and the cannulation after 4 days was successful. Actually, we extubated him from ventilator, then we decannulate him. The use of VV ECMO on these small infants needs a special cannula and expertise in cannulation technique, which was successfully done with the percutaneous technique by the pediatric intensivist, which opened the door for more cases to be treated with ECMO. There is a need for a pediatric ECMO center in Kuwait where babies with respiratory failure not responding to conventional therapy and reaching maximum support will benefit from this technology to survive the respiratory illness and give the lungs a chance to heal and normalize pulmonary function. This is our patient, and he was extubated, decannulated, and we examined him neurologically. He was okay, and he discharged home very well. In conclusion, successful ECMO for the patient, first infant with human metapneumovirus respiratory failure to be treated with ECMO in Kuwait. This is another case. Actually, we got it on 2nd of March, few days back before our conference. So this is again the drainage cannula, size 13, that's size 11. Actually, this patient is 2 months with 4 kg with COVID pneumonia and leukocytosis, and this is the returning cannula size 9. Thank you.
This topic is ECMO oxygenator change out during COVID-19 pandemic.
Good morning, everybody. First of all, I would like to say that I am not a doctor, I am a perfusionist. Today, my topic is about oxygenator change during COVID-19 pandemic. So, this is my hospital where we have done lots of cases during the pandemic. So, before going to change, we need to keep some things in our mind. That is, change out need to be planned as soon as possible when we detect that the oxygenator is going to be malfunctioning. So we have to act immediately. During this, we do not wait. Otherwise, that we have to hurry after further deterioration. On the other hand, we should not unnecessarily change the oxygenator also. So it will iatrogenic infection will increase, renewed blood dilution, inflammation, and oxygenator circuit and oxygenator will be used unnecessarily. So function of oxygenator mainly is to exchange the gases, and it is so artificially outside the body. So there is some membrane oxygenator that we use in ECMO that has some durability according to the company made recommendation. So what is the mechanism that the artificial lung or the oxygenator dysfunction? There are mainly three categories. That is hematological abnormalities, mechanical obstruction, and inadequate gas exchange. And another thing we have to keep in mind that I told in previous slide, that is the recommendation duration of the membrane. So, as I told, hematological abnormalities, the membrane lung activates inflammatory reaction when it comes in contact with the artificial circuit. So, it activates the thrombus formation, and thus it may need change. Another is the clot that form due to the coagulation and fibrinolysis, participation system coagulopathy or hemolysis, and with clot is deposited and obstructed in the blood flow path. And another is the gaseous exchange. The gaseous exchange may occur, there may be impairment in gaseous exchange, that is for deposition of moisture and cellular debris. So prevention strategy, that is the protocol that we follow during to prevent any type of oxygenator dysfunction. What are they? Monitoring the circuit and the anticoagulation therapy and minimizing the circuit exposure. How we do that? Monitoring the circuit parameter is to check the oxygen flow, the gas exchange, the pressure difference between the two part of the pre and post membrane oxygenator. Okay, and we have it has defined acceptable range for different oxygenators. So we have to keep in mind. The gas exchange transfer is between in adults it will be 3 to 5 ml. In pediatric it will be 4 to 6 ml, and in neonates it will be 6 to 8 ml. This is according to the ELSO guideline. So how do we measure the gas transfer? This is the formula that we use to measure the gas transfer. And the post-oxygenated ABG, the cutoff post-oxygenated ABG is 200 mm of Hg. So gas transfer is also measured that by CO2 clearance. CO2 clearance is the first which indicate the health of the oxygenator. If we can measure it by through the blood gas or through calculating the inlet and outlet CO2 clearance, and it must be at the maximum CO2 sweep gas flow. Sweep gas flow maximum means that different oxygenator have different sweep gas maximum sweep gas recommendation. So at that maximum sweep gas recommendation, it must be 10 mm of Hg. Okay. So we have made previously a analysis on the ECOR patient, which shows that the EtCO2 and PCO2 are the surrogate to each other. So we can also monitor the EtCO2 of the patient to identify the CO2 clearance. Anticoagulation therapy is one of the most important that we kept in mind in the when we are in the ECMO. That is, so D-dimer and the and blood test that gives the idea D-dimer, platelet count, and the APTT result. Visible clots are to be tested with the torch regularly, and minimizing the exposure. How can we minimize? Minimizing of the exposure to the circuit can be identified, can be done by different ways. This is the way that we use the circuit coating so that it can be somewhat nearly to our normal biological vein or arteries, and that makes the circuit to remove the clot or any other degradation. So this is the overall summary, and this is the statistics that we made over during our pandemic, and from 2014 we are doing ECMO, and total ECMO run is in the pandemic was 180, and of which we need to change the oxygenator 23. So percentage of oxygenator dysfunction was around 12%. And I got a study that also mentioned the overall difference in the malfunction of the oxygen is around 10%. So the key of my presentation is that we should act promptly, we should monitor the circuit and overall the physiology, which help to understand us the mechanism of clot formation in oxygenator. Thank you. Questions?
Thank you very much for a great review. We'll go to our final speaker.
The fact that you people are doing ECMO and you are embarking into very difficult cases of these critical illnesses, it's really commendable, and we really appreciate the presentations of all of you. Since I am a white beard person, I cannot just help but give an advice. And my only advice to all of you is that when you make presentations in a competitive actually session, one must stick to time, because time is a very important factor which the judges will consider always, because all these cases, all these presentations were equally good. So for I would say various reasons, actually we had the difficult tasks to judge first, second and third, but that doesn't take away anything from the excellent work that you all of you are doing in your institutions. And let's have a big hand for all the presenters. And then I'll request our chairperson to actually give you the results.
So thank you very much. And again, I just would echo those comments and also talk about what we saw as a theme going through many of these was folks doing things that had never been done before. Got our Kuwaiti colleagues doing the first cases in PEDS in Kuwait. We talked about you building teams during COVID when none of this stuff existed. Again, these are all things to very much be commended for, and I appreciate seeing here today. In third place, we will announce that Mr. Avik Dar for his presentation on oxygenator changes. We'll give you two of them later. In second place, Dr. Sulakshana for her discussion of COVID in the Indian population. And for first place, Dr. Siju Kumar for his discussion about neurodevelopmental outcomes. Congratulations to the winners and to all of the folks who presented today. Thank you.
Thank you.